Hi everyone, I'm Dr. Cliff Liebrack. I'm a professor in the Department of Obstetrics and Gynecology, University of Toronto in Canada, and I'm the director of the Create Fertility Centre, the largest fertility center in Canada. And I'm so pleased to be here to talk about IVF and embryology for dummies. And the outline of my talk is how does IVF work? What are embryos? And coming to terms with using a donor egg and motivations for women to carry a child for somebody else. I hope you enjoy my presentation. So IVF was actually first described in 1978 by Edwards and Steptoe, and Edwards won the Nobel Prize in 2010 for discovering IVF, and Steptoe unfortunately had passed before that time. So Louise Brown, the first baby born from IVF in 1978, she's over 40 years old now, and she also has children of her own. So IVF babies are having babies of their own. I like this slide because it illustrates what we try to mimic when we do IVF, in vitro fertilization. So firstly, the eggs from the ovaries are released, and then they travel down the fallopian tube, and fertilization happens towards the outer part of the fallopian tube. And then the egg starts to divide after it fertilizes. By day 2, it's about a 2 to 4 cell embryo. By day 3, it's about an 8-cell embryo, and then by day 4, it's called a morula, and then then later it becomes a blastocyst, which is about 80 to 100 cells, and then implantation occurs around day 5, 6, and 7. So moving on, this is what we do when we actually do IVF. We extract the eggs from the ovary, and this shows a video of an ultrasound of a needle going through into each follicle, and a follicle in the ultrasound looks black because it has fluid in it, and fluid looks black on an ultrasound dark. So as we go into each follicle, the fluid is aspirated. That's why it shrinks, as you see it here. And then we go into the next follicle and collect the fluid from that follicle. And inside that fluid are the eggs, and we have to fish the eggs out of the fluid. So this shows what an egg looks like, or oocyte, and around it is the zona pellucida, the coating around the egg in which the sperm must penetrate in order to fertilize an egg. So what are factors that affect egg quality? Well, the first is the most important, age. And we know that ovarian reserve declines quite rapidly after about the age of 45, and we call it a bi-exponential drop. So there's a slow drop through the 20s into the early 30s, and then by 35 there's a rapid decline where there's a much lower number of eggs as time goes by. We measure the ovarian reserve with a blood test called the AMH, and it's highly correlated with the response of the ovaries to the medications. And when we're using an egg donor, we want to have a very high response because we're looking for lots of eggs to be able to help, for example, same-sex male couples have children for both of the couples, both of the partners. And the number of eggs we get is also very highly correlated with AMH levels. Very high levels are associated with a condition called polycystic ovary syndrome, which I don't have time to talk about today, but that's a condition that we see causing fertility problems. Factors that affect egg quality also are genetic. So we also know that as a woman gets older, she has a higher risk of having a miscarriage. And in her 20s, it's about 10%. But when you get to in your 45, it's about 1 in 2, 50%. So it really rapidly increases with age of the woman. Hence, our egg donors tend to be chosen from younger age women. And the reason for this is because there are more increase in chromosomal abnormalities, the most common being Down syndrome. And if you look here at the age of about 20, in your 20s, you're looking at in the thousands of number of cases, 1 in about 1,000 cases of Down syndrome. Whereas when you get to 35, it's about 1 in 350 or so. And at 40, it's about 1 in 100. At 45, you're looking at about 1 in 30. So it's quite a rapid increase in the number of abnormal eggs. Another factor that affects egg quality is environment, and nutrition can help improve egg quality. We often give nutrients that can help the mitochondria or energy packages of the cell, because the egg has the most mitochondria of any cell in the body. And so we use things like coenzyme Q10 and PQQ as compounds that can be taken to help egg quality. We also use another hormonal medication called DHEA, which is also used to help egg quality, as well as other antioxidants and vitamin D. So the other thing that affects egg quality is the stimulation protocol. Women with very low ovarian reserve tend to do better with a low stimulation protocol. So what about fertilization? So we can fertilize eggs by just mixing them with sperm, or we can actually inject sperm into the egg. And this shows a technique called ICSI, or intracytoplasmic sperm injection, where a sperm is actually injected right into the egg. And this is a technique that's very often used in IVF to help with low sperm counts, and also used when we do genetic testing of embryos, as I'll talk about later. So this is what an embryo looks like when it has first fertilized. It's become a zygote, where there are two nuclei from the male and female that will then fuse to become the full nucleus of the embryo. And it then divides into two cells, each of them having a single nucleus. And then each cell then divides further as 4 cells, which is around day 2 of development. And also on day 3, it's about 8-cell embryo. Day 4 is where they become a morula. It's a compact cells. You can't really see individual cells very well at this stage. And then it becomes a blastocyst, and this is when it's about 80 to 100 cells. And the area here is called the inner cell mass, with the cell, that's where the baby comes from, and the cells around become the placenta, and which is called the trophectoderm. And that's where we biopsy the embryo to test if it's normal or not. This shows what happens as when the blastocyst actually hatches out of the zona pellucida, and this must happen prior to implanting in the uterus. So the other thing that's important in embryos is knowing which ones to choose to go inside the uterus. So there are different ways of selecting embryos. The most important ones are, firstly, genetic testing. So we'll talk about that first. And this shows the fertilization of the egg, growing them for 5 to 6 days in the incubator. We do lose a lot of embryos that don't make it to that stage. After about day 3, about 50% are lost, just naturally. And then the embryos are graded. We do somewhat of a grading system, but really grading is not very accurate, and I don't tend to rely on it very much. I rely much more on genetics, because that tells us if an embryo is normal or not. For example, each of these embryos in this slide had the same grade, but one was normal and one was completely abnormal. For example, Down syndrome here. So it's important to know that grading does not tell you whether an embryo is normal or not. So we have new technologies to test embryos for single gene defects, structural rearrangements, and the most common being aneuploidy, because that happens very commonly, is the most common abnormality in humans. Aneuploidy means the wrong number of chromosomes, like Down syndrome with an extra 21 chromosome. So embryo aneuploidy goes up as women get older, and you can see the curve going higher and higher as women get older. This shows our curve from our own lab, and showing embryos increasing as you get older. Now, getting abnormal embryos increasing as you get older. So when we do the pre-implantation genetic screening, we must do ICSI, because we only want to put one sperm in each egg and not have contamination from other sperm. And then we do a biopsy of the embryo, and we freeze the embryos. And there's no difference between a fresh or frozen embryo in terms of success. And embryos, it's been estimated you can keep them frozen for 10,000 years. So an embryo is biopsied as in this slide. So it shows the pipette that grabs the cells from the embryo, and a laser is used to cut off the cells from the embryo. And so we have a technology called next generation sequencing to tell if an embryo is normal or not. And this particular embryo has an extra chromosome 16, which is severely abnormal. When we look at egg donors, only about about 25 to 30% of those embryos are abnormal from an egg donor, and therefore we know that even at that age, that embryos can be abnormal, and hence it's useful to be able to only pick out the normal ones to go into a surrogate or intended mom. So genetic testing really has improved implantation rate, meaning the rate of an embryo implanting. It also reduces miscarriage rates because you're not putting embryos that are abnormal. And it also reduces multiple pregnancy rates because we don't put in usually more than one embryo. We don't need to because we can pre-select by testing them. Now, not every normal embryo will make a baby, so we need other technologies to choose which normal ones to go inside. And the best we have right now is called the one technology that does it is the embryoscope, where we do what's called morphokinetic analysis. So this shows an embryo that's growing inside an incubator using this morphokinetic analysis, where you're taking a photo every 20 minutes of the embryo over 5 to 7 days. You can see this embryo develop into all those stages we saw before into a blastocyst. Now, if we look at two embryos side by side, we can tell that embryos don't all grow at the same rate, and this tells us whether an embryo is more likely to implant in the uterus when its growth pattern is better than another embryo. So if we score embryos out of 10. So you can see at the bottom here, each embryo was scored differently. That was among the normal ones, because we don't score the abnormal ones. They're not going to be used anyway. And so this shows an embryo that was normal. This is abnormal. So obviously we're choosing the normal embryo. And our second line of choice is, here's a normal embryo that has a score of 10. Here's a normal embryo that has a score of 3. Obviously, we pick the one that has 10 because that's the higher score of morphokinetic growth. And mosaic embryos, I just mentioned briefly, is a type of embryo that has a different basically some cells are normal and some are abnormal, and all mosaic embryos have been normal, but they miscarry more often, so they're always our second choice. So moving on to success rate, well, if we use genetic testing, we can reach the higher success rate sooner because we can choose embryos that are normal. Obviously, the normal ones are going to be in there somewhere, but we're not able to select them well without genetic testing, and that helps us achieve a pregnancy much quicker. And if you're using a surrogate, you certainly want to get pregnancies that are not miscarried or abnormal or fail, because you may lose your surrogate after a while. So let's talk about the other issues that were in our outline, and that's who needs to use donor eggs to have a baby. Let's talk about donor eggs. So those are women that have no eggs from birth, and there are conditions like that. For example, androgen sensitivity syndrome, if anyone knows Jamie Lee Curtis, the actress, she has this condition. And if we did her karyotype, it would show a male karyotype. So she actually is genetically a male, but she's a female, phenotypically, in other words, outside. But she had testicles in her groin area that had to be removed to prevent cancer, and she doesn't have a uterus. So the only way someone with AIS would be able to have a baby is to use an egg donor and also a surrogate. Premature ovarian failure means that the eggs are destroyed after puberty, and they go into full menopause much earlier than someone normally would. Cancer treatments are another way that eggs are damaged by chemotherapy, radiation to the pelvis, and surgery to remove both ovaries obviously would remove the eggs. Poor egg quality and low egg reserve and failed IVF are all reasons why we might consider an egg donor, and I want to talk about those a little bit more in a second. And also, some women will meet someone when they're already in menopause, so their only option is an egg donor. It also allows us to prevent passing on of genetic conditions to offspring. And of course, same-sex male couples and single men all would need an egg donor to have children. So how do women sometimes come to terms with needing an egg donor? Well, for those people that have no other option, of course, men, and also women that have no eggs left, their only option is an egg donor, and I think they find it obviously easier to come to terms with because it's their only option versus adoption. So many of them will be able to have a child with their own partner's semen, and they can have a child that's genetically at least related to one of the two in the couple. And also, so what about those with eggs but have a low that have eggs but have a low chance? So they could either have poor quality eggs or low egg quantity or reserve, or they have multiple failed IVF. And these are women that have more trouble coming to terms with needing an egg donor, obviously. And so the key concepts that we find with these women is that it's very important for them to try all their options before turning to an egg donor. That's not their first choice. If egg donors are pushed early on to them, they will likely go to another clinic, another doctor, because they want to have that opportunity to try. And they must feel that they tried their best and will not regret going to the egg donor option. And egg donor is really not a time-sensitive thing because it really doesn't matter the woman's age as long as she has a uterus to use an egg donor. Whereas using your own eggs is very time-sensitive, as we've talked about. So these are some key concepts about coming to terms with needing an egg donor. Now, what about surrogacy? What motivates women to carry for somebody else? Well, I hear all the time women that are surrogates love being pregnant. They feel fortunate to be lucky enough to have children without difficulty. They may have had a relative or friend who had difficulty and saw their pain and suffering. And for many, it's the most important thing they have ever done in their whole life to help another person have a child. And often their family is so proud of them that they did this to help someone else. And they tend to be people who just love helping other people. In Canada, surrogacy is altruistic, so only expenses are reimbursed. Therefore, finances is not a motivator in Canadian surrogacy, which we're very proud of in Canada. And what do surrogates want in return? Well, unlike in Canada, in many countries they are paid rather than expenses only, and money is a motivator for those women. But they they want to feel very appreciated as a person, not just an incubator. They want a very good relationship with the intended parents. They want their privacy and space to be respected, and most love to hear about the children they've helped bring to the world in the future. Not every day, of course, but maybe when there's a birthday or holiday, to send them a picture, just give them a note about how the child they helped come into the world is doing in the future. So that's I think some of the main reasons, things that surrogates want in return. So Canada, I want to just talk a little bit, just the last slide, about why I choose Canada for doing your journey. Lower costs. We have a lower dollar cost, unlike the American dollar, and we have universal health care. So the surrogate's health care is completely free after she's pregnant, not the baby's care. You need to have insurance for that, but the insurance costs are much less than other countries. It's about 50% of the U.S. cost. We have guarantee programs of 1 baby, 2 babies, 1+1. We also have inspection and accreditation. We have high success rates, and our program at CREATE is university associated. We have a very large research program. And we can accept embryos from all of the countries, unlike the US where they have FDA regulations. It's a shorter time to find donors, usually days to weeks. Surrogates more in months. We have at CREATE excellent communication. We have 15 nurses that do this, and they're dedicated to this program, and you would have your own nurse coordinator to directly communicate with you. So I want to thank the Growing Families Group for inviting me to speak here, and I'm very happy to be proud to be part of this program, and I hope you enjoy your day. Thank you.